Hello, everyone. Thank you to the Georgia Commission on the Women's Wellness for allowing me to be here today and talk to you about our maternal mortality crisis. From a science perspective, we have mapped the entire human genome. We perform surgery on babies while they're still in a woman's uterus. And yet in the United States, and especially in Georgia, pregnancy is deadly, and the problem is actually getting worse. So how can that be in a country as wealthy as the United States? And how can that be in a country that has cutting edge care on technology and research? And yet so many mothers and babies are lost. So this presentation will focus on the gaps, the inequities, and while talking about this is so important, as an OBGYN doctor, I want to offer some solutions because we have to do something about this. This is a real life story of a woman who died from a preventable maternal cause. Please know that the majority of these maternal deaths are preventable. This is Kira Dixon Johnson's story. Kira was a 39-year-old, healthy, vibrant mom and wife. And on April 12 in 2016, she checked into Cedars-Sinai Medical Center in Los Angeles, California, which is a very prestigious hospital known for their excellent care. She was scheduled for a cesarean section to deliver her second child. The surgery was routine, it went really well, and her son was born very healthy. However, within an hour of delivery, her husband Charles noticed that something was wrong. So Kiara was in a lot of pain and was becoming increasingly sick, and she showed signs that there was something wrong. Charles repeatedly begged the medical staff to do something because she was getting worse and not getting better. But despite his concerns, Kira was not taken back to the OR until nearly 10 hours later. So Kira was taken back to the OR for emergency surgery, but that was about 12 hours after the first signs of any kind of trouble. The surgeons found over 3 liters of blood in her abdomen, but despite their efforts, she died later that night, just one day after giving birth to their second baby. Kira's case is a critical example of how preventable maternal deaths can happen even in top-tier hospitals, and how delays in responding in recognition and delays in treatment are often fatal. So her death launched the Kira Johnson Act, which is a part of the broader Black Maternal Health Momnibus Act. And her husband really became a powerful advocate for maternal health equity. The Black Maternal Health Momnibus Act is actually a comprehensive package of 13 consecutive congressional bills designed to improve maternal health outcomes. It makes critical investments in social determinants of health and seeks to expand access to maternal mental health as well as critical care health. And there are countless women's like Kira, countless other examples of tragedies just like this. These women are our friends, our mothers, wives, and colleagues. So the definition of maternal mortality is really simple. It's basically the death during a pregnancy or related to a pregnancy, during pregnancy, or up to 1 year postpartum. So again, any death during a pregnancy or up to 1 year postpartum. These are how the deaths are counted. So you will see numbers reported as pregnancy-associated deaths versus pregnancy-related deaths. And it's important to distinguish between the two. So pregnancy-associated death is due to a cause that's not related to the pregnancy. The mother just happened to be pregnant at the time of her death. So pregnancy-related deaths, on the other hand, are from pregnancy complications, from a chain of events that was initiated by the pregnancy or the aggravation of a medical condition from the effects of pregnancy. So maternal mortality is really an indicator of a nation's health. Okay, so the United States is in really bad shape, despite the fact we're one of the wealthiest countries in the world. So if you look at this graph on this slide, and this is up until 2018, but the United States, as you can see, has a significant higher maternal mortality rate compared to most other countries. Since then, it's actually gotten worse. And in 2021, the US had 32.9 deaths per 100,000 live births, which is more than double or triple the rate in many other high-income nations. For example, Norway's maternal mortality rate was zero in 2022. In 2022, Switzerland's rate was 1.2 deaths per 100,000, and Sweden's rate was nearly 3, not even close to the United States, which was at 22 deaths per 100,000 live births in 2022. So I know that there are some differences in how maternal mortality rates are tracked internationally, making direct comparisons challenging when you're looking at country to country. But nonetheless, these rates are extraordinarily high in the United States. And Black women experience significantly higher maternal mortality rates than white people do. And why is that? Is it access to care? Is it disparities in our healthcare systems? Is it racial inequalities? It's probably all that combined and then some more. And again, I don't want you to forget that a lot of these maternal deaths in the United States are considered preventable. So remember in 2021, we were dealing with the COVID pandemic. And in 2021, maternal mortality in the United States rose by 40%. Again, Black women were dying at greater than twice the rate of white women. So while the pandemic surely played a role, the fact is that the United States maternal mortality rate has been climbing for decades, and in Georgia as well. If you just look at the rate of the increase between the years of each race, the increases are much larger for non-Hispanic Blacks. As you can see from here, from this 18 to 2019 to 2022 to 2021, let alone for non-Hispanic whites, you can see the increase is not that much from there to there. So again, this is a problem of non-Hispanic Black populations, but exponentially so. Georgia has the second highest maternal mortality rate in the United States. In Georgia in 2021, 66.3 deaths per 100,000 live births, which was higher than the national average itself that we had talked about. So this is truly a maternal health crisis. Again, non-Hispanic Black women in Georgia experience substantially higher rates of pregnancy-related deaths than non-Hispanic white women. And again, a significant number of those are preventable. I share these alarming statistics with you because we all need to realize that this issue demands urgent attention by all of us. So like I said, Black women in Georgia are 2 to 3 times more likely to die from pregnancy than white women. Also, rural communities are affected, probably because of long travel times, and there's fewer hospitals there too, fewer clinics. And Medicaid-dependent women and uninsured women are more affected also. And why would that be? Because they have limited access to care before and during pregnancy and are more likely to experience adverse outcomes than women who have private insurance. So these disparities are sharp and very unjust. You can see the image here on this slide that shows, let me turn my cursor over there, that shows really that the dark areas, the dark orange areas in our state, that's about 35% of Georgia. And these are counties that are considered a maternity care desert. And another 16%, which is the lighter orange squares on there, those are Georgia counties that have limited access to maternity care, as represented, again, by that lighter orange. So if you combine the dark orange and the lighter orange, that's 51% of Georgia that has little to no access to birthing hospitals, to birth centers, or to obstetricians, which are the doctors who deliver babies. So, what are the leading causes of these deaths? These causes listed here are all pregnancy-related deaths. Remember, that's when the death occurred from a pregnancy complication or a chain of events that was initiated by the pregnancy itself, or again, the aggravation of some kind of medical condition due to the effects of pregnancy. So the most common causes are listed here. There's hemorrhage, mental health conditions, cardiomyopathy, heart and coronary conditions, embolism, preeclampsia and eclampsia are all blood pressure related problems that can occur in pregnancy. Most common causes are listed, and you can see they're pretty much the same from year to year, but all the causes really take a place in the lineup that's different every year. So which one becomes first in one year versus the other. Now, pregnancy-associated deaths, remember, those are deaths during pregnancy or within 1 year after death that are not related to the pregnancy. The patient just happened to be pregnant at the time of her death. So the top causes for those are car accidents, drug overdoses or toxicity from drugs, homicide, or suicides. So why is this happening? Well, lack of care, as we talked about with the maternity care deserts and low access areas, is really one reason why. And you should recall that hospitals in Georgia are closing maternity wards. You hear that on the news quite a bit. Mental health and substance misuse is a significant contributor to maternal mortality in Georgia, primarily because mental health conditions like suicide, depression, drug overdoses, they're really coupled with inadequate access to mental health as well and substance use services, right? Especially during the postpartum period. Chronic conditions like high blood pressure and diabetes contribute also because many of those health conditions are not managed well before pregnancy and certainly not managed well during pregnancy and after delivery. So it's critical to get this information and education to women. If you've had a child yourself, you know how particularly vulnerable we are right after giving birth with all the increased stress and hormonal changes that are going on, and all those things potentially exacerbate existing mental health conditions and substance use risks. And there's also a bias in healthcare that we can't forget about. Black women say that they're not being heard or believed when they don't feel well. So even if they have access to care, will they get adequate care compared to white women? So what's Georgia doing about this? And I'm grateful because there's been some movement here. We have a lot more to do, but at least Georgia's doing something. So I want to tell you a little bit about what Georgia's doing. So we have a maternal mortality review committee that was established in 2013, and it's supposed to be reviewing every single maternal death in Georgia. The legislators have extended postpartum Medicaid, which is great. They used to cover postpartum care on Medicaid for only 6 weeks, but now it's 1 year. So hopefully that's going to make a big impact on Georgia maternal deaths. Also, Georgia birthing facilities have been encouraged to implement practices that improve the quality of care provided during delivery and in the immediate postpartum period. And that's specifically to address hemorrhage, severe hypertension, and cardiac conditions. And there are also now verified levels of maternity care in Georgia birthing hospitals to help hospitals recognize and identify which patients that they have the resources to care for and which patients should be transferred to a facility that has more intensive services. So all birthing hospitals are encouraged to complete this maternal designation process, but not all of them in Georgia have done so already. We also have perinatal home visiting programs that are being established in Georgia, especially in underserved areas. And hopefully this will continue to expand because it really needs to. There are also programs like Healthy Mothers, Healthy Babies in Georgia. This organization focuses on advocacy for maternal and infant health, and they push education and access to resources. They like to share research and data in hopes that it'll influence policy under the dome in Georgia. I also wanted to mention that Emory University has a program called Peace for Moms, and it's a program that offers perinatal mental health consults and support to healthcare providers in Georgia, aimed at improving the mental health of pregnant and postpartum women and leading to better maternal and infant outcomes as well. But there's still a lot that needs to change. Access to consistent prenatal and postpartum care is huge. We need more community-based support. There are doulas, midwives, advocates that can help us with all this. Medicaid expansion still needs, to happen, and other ideas to help uninsured moms, right? Tackling racism in medicine is important in promoting cultural competency. If you ask me as a doctor, what would I like to see? I think every patient that delivers should get a blood pressure check and an exam 72 hours after discharge from the hospital. This is recommended now, not required, but this is recommended for patients with blood pressure issues like preeclampsia during pregnancy and during delivery. But, there are some infants that are typically seen 3 to 5 days after they're born, and I think postpartum women should be seen as well. What would that visit look like? At this visit, we could assess any depression, anxiety, obviously check their blood pressure, their blood sugars, and check up on them medically. But at that visit, we could also assess any social determinants of health, like their support structure at home, any nutritional needs they have. How are they bonding with the baby? How's the baby eating? Essentially give them resources for whatever they need. Are they breastfeeding okay? We have countless nonprofits that provide free diapers, transportation, food, etc. Most people just don't know about these, and they don't know that these organizations exist. So there's some other suggestions that we could do. We could have mandated autopsies for every pregnancy-related death, right? We could institute case management provision for every pregnant and postpartum patient. We could develop a valid instrument to screen for mood and anxiety disorders during pregnancy and afterwards. We could also mandate pre-pregnancy counseling if women are in their reproductive ages as part of their annual exams, especially if they have comorbidity. So essentially you're saying, hey, you've got hypertension. If you're thinking about getting pregnant, we really need to manage this and get this under control before you do that. So let's talk about that. We could also add education at postpartum discharge for urgent maternal warning signs and symptoms, and teach these women what a life-threatening symptom is and under what situations to seek care. So what else can you think of, right? Because we need to all think about all this, together. In my opinion, to improve the United States maternal mortality rates, and especially here in Georgia, it's going to take some bold, systemic, and innovative strategies to really do this. And in my opinion, we have to think outside of the box, right? So I came up with several ideas just because I don't just want to talk about this problem. I want to offer some solutions. And so all of these items that I was thinking about are all outside of the box. Okay, so this one is an outside of the box thought using technology to support early diagnosis and preventive measures, right? So pregnant patients are all at risk. And maybe pregnant patients in general should have this, but especially those at high risk could wear a device tracking certain things like their blood pressures or blood sugars, or maybe even the fetal heart rates, right? Enabling early detection, timely intervention for complications during pregnancy and during the postpartum period as well. In areas especially that have limited access to prenatal care, these devices can assist in regular check-ins without travel. So again, making care more equitable in my mind. Since most maternal deaths occur postpartum from things like hemorrhage, hypertension, and infection, maybe these remote tools could track postpartum blood pressure, oxygen saturation, pulse rates, and maybe even some specific postpartum symptoms to look for things like, say, if a patient is at risk for postpartum depression. Personalized alerts can be tailored for specific patients and can be integrated with even telehealth visits. Obviously, these devices would reduce the delays in seeking help, of course, too. But again, this idea kind of shifts investment from reactive care to more preventive tech-enabled solutions. And why not get Silicon Valley and our engineers at Georgia Tech interested and invite them into the aspect of maternal care to make a difference. This is another idea. Maybe we could develop a Medicaid doula corps, which would be federally funded or maybe even partially state funded, to train and deploy a corps of really culturally competent doulas, midwives, patient advocates inside the Medicaid system. Because again, these caretakers are really community-based supportive, especially for underserved women, and it would move the workforce model beyond the doctors. But this could essentially transform maternal mortality, specifically for vulnerable populations. And why or how? I think because this core would offer clinical, non-clinical, emotional, physical, and informational support across the perinatal timeline from pregnancy into postpartum period. They would build trust. They'd provide community of care or continuity of care, rather. They would identify red flags early and advocate for appropriate care at that time. Studies have shown that doula-supported births and midwife care actually has lower C-section rates, lower preterm labor birth rates, higher breastfeeding initiation. All of those are linked to better maternal and fetal outcomes, right? So this core could even assist with transportation, appointment scheduling, insurance and benefit issues and questions, providing education and enhanced understanding of those ever important discharge instructions, right? And they could act as a bridge between the patients and the doctors. Social determinants of health could especially be addressed here. And this program really mitigates systemic bias and provides culturally concordant care, like I talked about, and empowers patients through education and accurate information. So I like that idea. Here's another really good one. We could use zip code data to predict maternal risk zones, and then we can fund localized interventions accordingly. This uses urban epidemiology and technology to drive equity-focused policy, and we could apply that. So again, pinpointing high-risk zip codes allows agencies and healthcare systems to deploy maternal health mobile units, especially temporary or permanent OBGYN services. We could offer community-based providers and outreach workers and provide, again, transportation and even telehealth support. So the key is that limited resources, because we don't have an unlimited amount of resources, but those limited resources could be really focused where they're needed the most and where they can have the greatest impact. And what's interesting is that zip code analysis can reveal what areas lack prenatal and postnatal care. They can track what populations have late or no prenatal care. They can even tell us where high numbers of births are occurring outside of hospitals. So this idea correlates social determinants of health because high-risk zones for pregnancy are often going to be high-risk zones also that overlap with poverty, with unstable housing, with transportation deserts, with environmental risk factors, high populations who essentially face systemic barriers and biases in care. Okay, so once these high risk areas are identified, then community-based programs could even apply for grants and funding and start home visiting programs and even organize, local education campaigns, which will have an effect, on all of this, evaluating and adjustment of policies even. So this is another fabulous idea, I think, that could dramatically reduce maternal mortality, especially in high-risk groups. The fourth trimester is defined as the first 12 weeks or 3 months after birth, which is a critical period for physical recovery, mental health, infant bonding, breastfeeding, and medical follow-up. The women who would qualify would actually get paid time off. They would get access to medical and mental health care. They would get social support services like childcare help, breastfeeding support, meals and transportation, and they would have coordinated care navigation systems. Since many maternal deaths happen after hospital discharge, this program would ensure that these patients attend follow-up visits and/or they receive home visits or remote monitoring if needed. So it's interesting that only 40% of postpartum Medicaid patients attend their 6-week follow-up visit. And this program would substantially shift that, because for all the reasons why these patients potentially don't make those appointments would now be taken care of, right? Low-income women are often required or forced to return to work within 1 to 2 weeks after having a baby, which increases their risk for wound infections, postpartum depression, anxiety, stress, suicide thoughts. And I love this program because there would be social and systemic equity in recovery time for these women and provide standardized support for them. Okay, we could also pair every high-risk pregnancy or every pregnancy that's in those high-risk zones with a non-clinician mom coach who are trained in mental health, first aid, system navigation, and peer support. So this would build that scaffolding around vulnerable patients, but yet not add burden to, our hospital healthcare systems, right? So these mom coaches would likely come from the same communities or demographics as the patients themselves. So mom coaches could be trained in maternal first aid, like recognizing emergencies, but they would also know basic health navigation, how to provide emotional and social support, and would also know how to respond in a crisis and how best to de-escalate that. They would be swift as referral systems, or they would have all the referral systems in their pockets to be able to help these women. So again, this would facilitate early detection of those red flags or those emergency situations and encourage patients not to dismiss any symptoms. Mom coaches are trusted and considered community insiders, but not necessarily part of the medical system. So patients might actually be more apt to voice concerns and ask questions than they would when they're feeling intimidated by medical personnel for whatever reasons, right? So these mom coaches could accompany these patients to their appointments, and it's well known that trust saves lives. So this would just be taking advantage of that. We could also use Uber or Lyft for emergency OB transport. This could be a public-private partnership, which I love, with rideshare companies to guarantee these fast delivery stuff. Again, this treats transportation as critical infrastructure for maternal survival. And what it's great is that you don't, with all these hospitals closing and the maternity wards closing, we don't have to rebuild the infrastructure overnight, right? This would help us get there in the long term, but help us out in the meantime. So again, many maternal deaths are linked to missed or delayed medical care. Patients may not have a car, they may not have reliable public transit available to them, and often they have family or work obligations. And missed visits are strongly correlated with higher risk of pregnancy complications and maternal death. And of course, if there's an emergency, those pregnant women experiencing signs of things like preeclampsia, early labor, bleeding, or a quick labor or fast labor would, if they had transportation available to them, the outcomes might be different. So no-show rates, again, for maternal health and mental health and specialty care would decrease. In Georgia, remember, 82 counties have no OB unit, and many women have to travel 30 to 100 miles to access OB care. So this transportation system, would help fill this gap. We could pilot this, like we talked about earlier, those high-risk zip code areas that we talked about. This is a powerful tool to think about maternal justice audits that are required every hospital to go through that has a labor and delivery unit every 3 years. This goes beyond clinical review and centers more on equity, lived experiences, and systemic accountability in analyzing labor and delivery outcomes. Okay, so this audit would look at adverse outcomes and patient experiences as well. They would identify preventable system failures and expose racial bias and inequitable treatment. Also, it would improve communication and team culture, all validating the patient's voice and the patient's experience and creating actionable change. So there are already models of this in practice in other parts of the country. So it wouldn't be hard to do something like this in Georgia. Engaging male partners in maternal health through education, emotional support, and shared responsibility can also significantly decrease maternal mortality rates by improving care-seeking behavior, early detection of complications, mental health support, and continuity of care. So in many families, male partners influence when they get care, where they get care, and how warning signs are responded to. But rarely do our maternal health systems include male partners, right? And they have the power to affect outcomes, I believe. So male partners reduce maternal stress big time when they're supportive, right? There already are programs for this. The World Health Organization has a program called Engaging Fathers for Child Survival Program. The United States has a program called Healthy Start Fatherhood Initiatives. And there's a great group that I'm not sure if you heard of in Georgia called the Black Men for Maternal Health. And they have workshops for dad's first aid and father-centered support groups already in place as well. So again, it's just utilizing these to a higher level. Especially if, again, establishing a digital public-facing archive of stories from families affected by maternal death or near misses, which are important as well, can be used, okay? Especially if this archive is centered around Black, Indigenous, and low-income voices. This could play a very powerful role in reducing maternal mortality because it really humanizes the crisis and can drive policy change. Right? It can even shift provider behavior, perhaps, and empower at-risk families. So think of this as the every name counts of maternal health to counterbalance the dismissal of statistics. Statistics tend to be very dry, but this public-facing archive with stories will really humanize these statistics. This archive could be hosted by a coalition like, say, the March of Dimes with Black Mamas Matter, and even local universities. And again, a lot of people have funding, available for ideas like this that would make such an impact on maternal mortality. I think everyone really wants to do something about this, but don't really know where. So some of these ideas, just need to be brought up and say, hey, what about this? But this could be a story-driven accountability movement, really. Okay, so the last thing I wanted to bring up is this a kind of clinic like this one. It's mobile. It's a pop-up prenatal care clinics that could be, pushed out to remote areas and underserved communities so that we can help meet these patients where they are and help them overcome barriers to access. This kind of clinic would obviously bring prenatal care and postpartum care directly to underserved communities and would decrease maternal mortality rates by limiting access barriers, improving early detection of complications, and connecting at-risk women to life-saving resources that they need but don't know about. So these days, there's really great technology for the mobile clinics to even have ultrasound available. And a lot of education would be given at these prenatal care visits as well. This would obviously increase access to early and consistent prenatal care, detect high-risk conditions sooner, and improve postpartum care follow-up and even fourth trimester care if we talk about that. So this is an example of a direct intervention that really would not be hard to implement here in Georgia and expand on it where it's already occurring.